Well, good afternoon, everyone, and welcome to our monthly geriatric medicine town hall. It is an absolutely gorgeous day outside, and we appreciate you taking the time out to spend with us. But then we also want you to get outside and get some dwindling vitamin D that might be life-giving from the sun. So with that, we have a great speaker today, and I'm going to pass on to our moderator, Susan Edgman-Levitan.
Thank you, Dr. Russell. Welcome, everyone. The town halls must bring good weather, because all of our town halls this year, we've had wonderful weather, which has always made us worry, will anyone show up? Because they can be with us or they can be outside. So we're very happy you joined us today. My name again is Susan Edgman-Levitan, and I'm the director of the Stoeckel Center for Primary Care Innovation at Mass General. So a few housekeeping rules to remind everyone of. All of the participants are muted to eliminate background noise. So I'm just letting you know that, because you actually cannot unmute yourself. And that helps us prevent any mistakes or any interruptions for our speakers. You can view the speaker on your full screen, or you can go to the gallery view where you can see everyone. If you go up to the upper right-hand corner of your screen, and there's a little box there where you can click on whether you want to see the speaker view, the gallery view, etc. If your picture becomes jumpy or it gets out of sync, sometimes that happens because your internet connection may be a little weak, and it happens also if we have a lot of participants. So if you click stop video in the lower left corner, you'll see a little video camera. If you click on that, that will stop your video. And the only thing that will happen is we can't see you, but you'll still be able to hear and see everything. We also want to remind you that we really want to hear your questions. And the way that you submit them is through the chat function, which is in the very middle of the bottom of the screen. And you click on that, and then you can write in your questions, and I'll be monitoring the questions throughout the presentations. The only thing we ask is that you not share any personal medical information. We really don't want to see any rashes or anything you might want to show us, because anything you show on your screen, every single person in the Zoom is able to see. But if you do have a medical question, please reach out to your doctor directly to check in with them about that. We've got great speakers today, so I want to get right to the presentations, because I think we're going to hear about some very important topics. So today, you're going to hear from Dr. Matt Russell, who is the clinical director of the geriatric section and the medical director of geriatric medicine here at Mass General. And then you're going to hear from one of my favorite people and colleagues, Dr. Michael Berry, who is the director of the Informed Medical Decisions Program and within the Health Decision Science Center at MGH. And Dr. Berry is also a member of the U.S. Preventive Task Force, and that's what he's going to be talking about with us today. So with that, I'm going to turn this over to Dr. Berry.
Great, I will share my screen. And I want to be sure you're seeing the full slide view. I see nodding, so we're good. So I'm going to talk about two things today that are related. One, I just want to tell you a little bit about the U.S. Preventive Services Task Force and how it operates. And then I'll talk a little bit about our recent draft recommendation, not final recommendation as yet, on starting aspirin. And I'll emphasize those 2 points as I go on. So, and I have some disclaimers I need to use as a member of the task force. So the first part, Task Force 101, I'm doing on behalf of the task force. Although I'm a member, the discussion on aspirin represents my individual views and not necessarily the views of the task force, because the recommendation is not final yet. And I'll talk to you about that a little bit. And for everything you wanted to know about the task force, you can go to our website. So What's the task force? So we're an independent panel of non-federal volunteer experts in prevention, evidence-based medicine, and primary care. We serve 4-year terms. There are 16 members, including 2 vice chairs and a chair. I'm currently one of the vice chairs and will take over for chair year after next. There's a rigorous conflict of interest review because there's great concern about conflicts of interest creeping into guidelines. And you can go to our description of members and read all about our conflict declarations and what we've done in terms of our research career. So our goal is making evidence-based recommendations about clinical preventive services to improve the health of everyone living in the United States. And that includes screening like colorectal or lung cancer screening, counseling like healthy diet, and preventive medications, the focus of the aspirin recommendations. And I'll also talk about how statins fit into that picture as well. We only address services offered or referred from primary care. So our focus is really on primary care, and it focuses on adults and children with no signs or symptoms of disease. So this is not about diagnosis of existing symptoms, but it's about screening or counseling or preventive medications in asymptomatic people. And that would include pregnant persons as well. So a little task force history. The task force actually formed in 1984 in the Reagan administration, created by Congress and convened by the US Public Health Service. The first guide to clinical preventive services was published in 1989. Then a second task force was convened, which led to the publication on the right, a book that many of us in clinical medicine used at the time. We're now, of course, all online. And eventually the support responsibilities were transferred from the Public Health Service to the Agency for Healthcare Research and Quality. It's actually HRQ that appoints the members and the chairs. Of significance, in 2010, the Affordable Care Act required private insurers, interestingly, it didn't mandate this for Medicare or the Medicaid carriers, to cover services that we designate as A and B, services that we recommend, and I'll get to how you get to an A or a B soon, without a copayment. So that makes high quality and high evidence screenings hopefully more accessible to people. Interesting, many people think we're a creation of the Affordable Care Act. We go back a lot further than that, but it's the link to insurance coverage. And we currently have about 50 A and B recommendations that, again, are required to be covered by private insurers without copayments. Now, this is a busy slide, but I'm just going to walk through it to tell you a little bit about our processes. First, in terms of tackling a topic like aspirin, anyone, including anyone on this conference, can go to our website and nominate a topic. We both tackle new topics that people bring to us, or every 5 years or so, we update existing topics, including, in this case, aspirin. The first step is developing a draft research plan, because evaluating the evidence is a key part to our eventually forming a recommendation. That's done using an analytic framework, which I'll show you on the next slide. And importantly, we're very transparent. So the research plan as a draft goes up on the website for public comment, and we take all those comments seriously. We then finalize the research plan, and an evidence-based practice center funded by the Agency for Healthcare Research and Quality goes off to do the systematic reviews that we use to collect the evidence addressing our key questions. We then review that evidence and develop a draft recommendation, which again goes up for public comment, so that anyone, clinicians, organizations, people can comment, and frequently do. This is where aspirin is at. It was actually posted in October for public comment. The press picked up on it, I think creating the idea in many people's eyes that it was final, but it is not. We're digesting those comments. It usually takes several months. We take everyone seriously before we publish a final recommendation. And that will happen with aspirin probably over the next several months or so. Next, oh, I'm sorry. I'm the next slider. So this is just an example of an analytic framework. This happens to be for the screening for atrial fibrillation. We look first for, and each of these circles on the analytic framework, that's what the reviewers look for evidence on. So here we might ask, does screening for atrial fibrillation reduce mortality, prevent strokes, etc. There's been very little of this direct evidence so far, but it's coming for atrial fibrillation. Often we make decisions based on what we call an indirect pathway. We ask the question, does screening find atrial fibrillation? And then once we find it, does the kind of atrial fibrillation we detect through screening lead to improvements in outcomes? We're always very careful looking at the harms of screening and treatment, and that will come up in the aspirin discussion. Again, just an example of how we proceed.
Michael, can
Yes.
I interrupt you just for a second?
Sure.
You used a term that I want to make sure everyone understands. So you talked about how when you go through the whole process, eventually in the pipeline, the staff at the Agency for Healthcare Research and Quality do a systematic review. Can you explain what a systematic review is?
Sure. So it's looking for published evidence, particularly clinical trials that address those key questions. So we would look for clinical trials, for example, in the atrial fibrillation example here, the screening for AF improve health outcomes. And we would look for largely trials. Sometimes we use other kinds of evidence, but clinical trials where people are randomly either screened for AF or not, and then we count the outcomes at the back end. And it's those kind of studies that form the heart of the evidence reviews for our recommendations. Thanks, Susan. So just in terms of how to get to those A and B recommendations that determine whether the ACA would mandate coverage for them, we basically judge both the magnitude of the net benefit, and when I say net benefit, that's benefit minus harms, and then we look at the certainty of that net benefit based on the quality of those studies that we review. It's a relatively high bar to get an A recommendation. There has to be a high certainty of a substantial net benefit. Screening for hypertension is an example of an A recommendation. For moderate magnitudes of net benefit or moderate certainty, that's a B recommendation, a little bit weaker than the A, but for practical purposes, it still means we think clinicians should offer it to patients, and the ACA would mandate coverage by private insurers. In situations, as we'll get to with aspirin, where we're either highly or moderately certain about a small benefit, that's a C recommendation. We think that could be offered selectively. Patient preferences play a role, as they always do. And then if we're high or moderately certain of no benefit or even more harm than good, a negative benefit, that's a D recommendation, recommendation against. If we are just uncertain, we make an I or insufficient statement, and that's basically we develop a call for more research. And we've just submitted, as we do annually, our call for research to Congress to try to stimulate research in gaps that we have. So that's a little bit about the background of the task force. Again, A's and B's do routinely, C's selectively, D is not due. So I'm going to stop my share for now. And let me talk a little bit about aspirin. Close that presentation. And I've got another share we'll do in just a minute. So again, two things I'll stress about the draft recommendation for aspirin. First, it's a draft, so there'll be the public comment period has just closed. We take all those seriously, and that will eventually lead to a final recommendation. The other point I'll make is this was an analysis about starting aspirin, not stopping aspirin. That's a big difference, particularly for people who are on aspirin because of some evidence of cardiovascular disease, which can be quite broad. Now, what we had, our draft recommendation says that for people age 40 to 59, we recommend that they talk with their clinicians, estimate, and I'll show you how you can do that from a risk estimator called the pooled cohort equation, which is used in many circumstances in cardiovascular medicine. And if the risk of a heart attack or stroke over the next 10 years is greater than 10%, to just have a conversation with our clinicians about both the harms and benefits of aspirin. That's age 50 to 69. 40 to 59. And then for 60 and older, our analysis came up with a D recommendation not to initiate aspirin. Again, these are in people without evidence of cardiovascular disease when they're making the decision. And that's the heart of the recommendation. Now, there were in our previous recommendation, we had addressed colorectal cancer screening. There was some evidence at the time suggesting maybe there was an effect on colorectal cancer incidence and mortality. That evidence is now much weaker. It goes in different directions. And what I would emphasize here, we don't address aspirin for colorectal cancer prevention, but it turns out that if you want to lower your risk of dying of colorectal cancer, the best thing to do is get screened regularly, which has a substantial effect. And that would be the better approach. And I'll just emphasize that it's important not to see these interventions one at a time. In other words, the real question patients and their clinicians should be discussing is, what can I do to lower my risk of dying of colorectal cancer? What can I do to my risk of either getting or dying of a heart attack or stroke? And I would emphasize that point. Now, in the same way, I would want to emphasize that there are multiple ways one can reduce one's risk of dying, of getting or dying of a heart attack or stroke, separate from aspirin. And I want to just emphasize certainly, healthy diet and lifestyle, maintaining a good blood pressure. These are all things that we have other recommendations about. And I'll just emphasize in terms of preventive medicines, the role of statin treatment for reducing the risk of heart attacks and strokes. And I'm going to share my screen once more.
Michael, while you're sharing your screen,
yeah.
Would the example you just gave of aspirin to reduce colorectal cancer be an example of what you called an insufficient evidence?
Correct.
Yeah, okay.
Correct. And again, we call for more research in that case as we do here. But
Right.
Again, I would emphasize that for colorectal cancer prevention, and particularly for preventing dying of colorectal cancer, we've got a good alternative strategy that doesn't have controversial or equivocal evidence in terms of screening.
Yeah.
Okay, now can you all see there's a chart in different colors on the screen?
Blue
share?
and yellow.
Okay, now
Yeah.
this is again crowded, but I just want to emphasize a couple of points. I mentioned the pooled cohort equations, which many guidelines recommend for people who want to estimate, ideally working with their clinicians, their risk of, say, having a stroke or heart attack over the next 10 years. And what I've done here, and this is available on the American Heart Association website and many other sites, it's commonly available, and you can interact with it. I've just put in some characteristics for a man who's 65, who's white, and this is a so-called race-aware model. There's a lot of controversy about how we incorporate race into models, but a topic for another day. And I've given this fellow a pretty good cholesterol profile. He's got a total cholesterol of 180 and a really good, helpful HDL cholesterol of 60. So that's a good cholesterol profile. I've given him high blood pressure, but it's well controlled with a systolic blood pressure of 120, no diabetes or smoking. Those are the variables that go into the pooled cohort equation. And the output I'm going to focus on is this column in blue, which gives us an estimate, and really only an estimate, of the 10-year risk. The estimated risk here would be about 11%. Now, many people would say, statins, why would I take a statin to prevent a stroke or heart attack? My cholesterol is really good. Well, this man's cholesterol is really quite good. And the interesting thing about statins is it appears they can lower the risk of strokes and heart attacks in some ways out of proportion to their cholesterol lowering effect, which can be quite potent. But the theory is that these medications can help stabilize the plaques in, say, the coronary arteries that can fracture and lead to stroke, perhaps an anti-inflammatory effect. I noticed that's come up in the question. So a man like this, even with a good cholesterol, might be able to reduce his risk by 25% to 30%, taking a statin down to, say, 7 or 8%. Probably more potent than we'd expect from any effective aspirin. So we do have recommendations on statin therapy that are widely done. That's not to say everyone should be on a statin, but in terms of tools to reduce the risk of stroke or heart attack, that's a big one. So I think we're at the end of the formal comment period, and I know we've got some other things to talk about and then come back to your questions. So I'll stop sharing. So stay tuned for the final recommendation. Remember, this is not final yet. Have I said that enough times?
Yeah. Thank you, Dr. Berry. And we're going to go to Dr. Russell.
Great. Thank you, Dr. Berry. That was a wonderful discussion. You know, we always need refreshers in this as primary care doctors, because so many times various studies will come out and, you know, how this study varies from that study. It's nice to have folks helping you put this together as a clinician so you make the best recommendation, you know, for your patient, work with them on something that's really intrinsically important to them. On that topic, in geriatric medicine, actually throughout all of the specialties in medicine, the American Board of Internal Medicine has started what's called a Choosing Wisely campaign. And what that is a very thoughtfully arrived at list of specialty-specific recommendations for physicians and their patients. So for example, one very big recommendation from that is the use of artificial feeding in advanced dementia. We will often, more on the inpatient setting, have conversations with our patients' family members about this as their disease progresses. And the decision to provide artificial nutrition is very tempting, because when someone is no longer able to feed themselves, it can be very distressing for everyone. But over time, with research, we have actually got evidence that very clearly says placing feeding tubes in this subset of patients actually doesn't improve quality of life or life expectancy. And if you go and look at the ABIM, American Board of Internal Medicine Choosing Wisely campaign, and look under patient information, you'll see all of the various recommendations. Sometimes in geriatrics, we just don't have a clear way forward. And that's why it's so important for our patients and their families to have some guidelines, some, you know, what do we do in this case? So the next thing I just want to talk about is some just nuts and bolts about what's going on in our clinic at Yawkey 2, the Geriatric Medicine Clinic. You may notice when you next come into the office that there are some new faces. We have had some new patient care managers, so that those are our administrative staff hires. And we've also had our new medical assistants hired. So please feel free to introduce yourself to them and be patient with them as they're learning the ropes. It's a lovely place to work, but sometimes things aren't obviously very straightforward when you're just starting a new job. In terms of the boosters and vaccines, just wanted to remind you that if you have not yet reached out to your pharmacy, your local pharmacy, to set up a COVID booster, please do. And also try to get your flu shot. If you are going to get your flu shot at your local pharmacy and you are over the age of 65, please make sure that you receive the high dose flu vaccine and not the regular flu dose vaccine. Sorry, the regular dose flu vaccine. The last thing I just wanted to talk about is that as we're going into the holiday season, many people are thinking, gosh, what am I going to do to keep myself safe? How am I going to prevent being part of a holiday-related uptick in COVID? And I just want to resurrect the term risk mitigation. I know we've talked about this in prior town halls. If you feel like you're going to be if you are going to be traveling in public transportation, whether that's planes and automobiles or trains, please make sure that you are wearing a mask and try to minimize taking that mask off unless you are eating or drinking something. And if it's a short trip, maybe don't even eat or drink something. When you are with family, and you think you might be around unvaccinated people, it is reasonable to wear a mask for yourself and for others. And if it's something that little children want to hug you, again, the answer is risk mitigation. If you wear a mask and you wash your hands, these things we know. How many of you have gotten a cold since you've had to wear a mask? I haven't had a cold in 18 months, and I'm someone who gets a cold every hot minute because I ride the subway. So masks work, hand washing works, and these are ways to just ensure that you can enjoy your holiday with peace of mind. So with that, I'm going to pass it back to Susan for the question and answer part.
And thank you, Dr. Russell. And actually, I just want to add a piece of information about something that Dr. Russell mentioned. And it's actually also related to Dr. Berry's comments. You all are all going to see a message in Patient Gateway, probably next week, that is going to let everyone know that wherever you get your vaccine, there's a statewide registry that our doctors will be able to access. And the reason I'm saying this is that right now, and we've talked about this in previous town halls, a lot of our practices and our doctors are pretty overwhelmed with the number of Patient Gateway messages they're receiving. And so we're trying to do our best to get information to you that eliminate some of those messages. And so the point of this, of the statewide registry, is that if you go to your local CVS or your grocery store or Walgreens or whatever and get a vaccine, you don't have to worry that you have to send a message to your doctor or nurse practitioner at Geriatric Medicine, because they will be able to see that information in the statewide registry and know that you're covered. The other thing that we're asking is that we also are getting questions, a lot of questions from people, because so many people have had to postpone various screening tests and getting like a tetanus shot or whatever. And so a lot of people are sending in messages about that to their doctors. This is the kind of thing where it's actually most helpful if you actually schedule a virtual visit or an in-person visit, because that information is probably more tailored to you, and it's often hard to respond to your questions efficiently on Patient Gateway. So we're just sharing that with you because we're trying to get all of our patients all the information they need, and we're also trying to take care of all of our clinicians who are working as hard as they've ever worked and trying to respond to all of your needs in an efficient and fast way. So with that, I'm going to move to the questions. So I have another question for Dr. Berry. We've got some questions that you've submitted, but Dr. Berry, you one of your examples I think was very helpful, showing the risk calculator. And so I'd like you to say a little bit about risk calculators, because these are things that anyone can go information in and get a little bit more information about how much at risk they are. And so I'd like you to maybe say a little bit about risk calculators that you think are evidence-based and trustworthy, and that we may want people to know about so that they can use them.
Sure. Well, let me just say that this is an interesting time in the history of risk calculators, because there's some controversy about these tools to estimate risk, particularly around the inclusion of race as a variable. I talked about race-aware models in the pooled cohort equation, which may be the most widely used of those estimators, uses race, white and others versus Black. And if I had remember the patient that I had, the hypothetical patient I put in had about an 11% 10-year risk. If I had made that patient Black instead of white, that risk would have been about 13%. People may jump to say, well, there's a biological issue then that with race that increases risk. And the alternative view, which there is growing evidence for, is that race is more a social construct than a biological variable. And in fact, what we may be seeing with that higher risk is the effect of racism, not race. So there's a lot of study going on now about how we incorporate race into calculators. That aside, getting a good sense of your baseline risk for a condition is a pretty good way to figure out whether treatment might make sense. So I could tell you that, let's say, statins will reduce your risk of a heart attack or stroke by 30%. But if your 10-year risk of a heart attack or stroke is 3%, that means going from 3% to 2%. Which may not seem very large to many people. On the other hand, if your risk is 15%, we're talking about, reducing that down to 10 or 11%, a much bigger absolute difference. So knowing your baseline risk is helpful. The pooled cohort equation is one I would emphasize in particular. There are calculators for women that can estimate their risk of developing breast cancer over time. And those calculators may be helpful in making decisions about whether to take medications to lower the risk of breast cancer, medicines like tamoxifen, raloxifene, and the aromatase inhibitors, which don't make sense for women at low risk, but may make sense for women at high risk. So that's another example. That also is a race-aware model that's being wrestled with in terms of its accuracy. Final example, there is a calculator to estimate a woman's 10-year risk of an osteoporotic fracture, like a hip fracture, based on her clinical characteristics, age and body mass index, et cetera, as well as her bone density measurements if she gets a bone density measurement. And that estimate of risk can help decide whether taking, say, a bone strengthening medicine, in addition to exercise, calcium, and vitamin D might be a reasonable thing to do. So stay tuned. There's going to be a lot more on risk estimators in general. They can be helpful in deciding whether an intervention, preventive or otherwise, is worthwhile for you.
Thank you. And I think your examples also illustrate why when people are thinking about preventive measures, it's important to have a real conversation with your doctor, either in person or virtually, because there are a lot of risks and benefits of the different options that need to be considered, that are personal, that are hard to address in an email message. I want to move now to the questions that we got, the very thoughtful questions that we got from people before today's town hall. So I'm going to start with a question about a study that was done. The question was, did the Preventive Task Force pay much attention to the risk of discontinuing baby aspirin? And the person who submitted this question included some studies that were done in Sweden. And Michael, I know you're familiar with those, and I just want you to say a few words, because I think this question is about something that's a little different from what the recommendations are actually may focus on when the final recommendations come out.
Sure. Well, I'll just emphasize that this draft recommendation was about starting aspirin, not about stopping aspirin. And the evidence may well be different around stopping aspirin. For example, one of the downsides and one of the reasons for the de-recommendation for starting aspirin in general for people 60 and older is that while the decrease in risk of a heart attack or stroke, non-fatal heart attack or stroke, is relatively modest, about a 12% reduction, and no statistically significant reduction in fatal strokes or heart attacks with aspirin, the risk of bleeding goes up considerably. The risk of bleeding from the gastrointestinal tract, the stomach or intestine, goes up about 60% with aspirin. And because older folks are at higher risk, that relative risk will mean a bigger absolute risk of bleeding. And maybe even more importantly, the risk of a more disastrous bleed, a bleed inside the head, goes up about 30%. So that's why as you get older, the risk-benefit equation sort of swings against aspirin. But what we don't know is if someone has been on aspirin for 10 years, has not bled, whether that changes the risk of bleeding in a more favorable direction. And certainly if anyone has evidence of cardiovascular disease, that swings the pendulum more toward aspirin. So this was a Swedish study that looked at a population of about 600,000 people in Sweden who were in a database that had their prescribing information. Aspirin gets prescribed to Sweden. And what they had done is they looked at heart attacks or strokes in the window after people stopped aspirin and showed a higher risk. The challenge is that most of the people in that study were on, or had actually had a hospitalization for a heart attack or stroke, which would definitely be an indication for continuing aspirin. And even if the people who didn't, of course, many people with cardiovascular disease haven't been hospitalized for one of those events. And we don't know how many of those people were involved in the population involved. But that just, to me, emphasizes that if you've got an indication for aspirin, that may well mean staying on aspirin is the right thing. And that's why we would suggest conversations with people's clinicians about continuing. Certainly I worry the press coverage a bit. While we were focused on starting aspirin, many people interpreted as recommendations about stopping aspirin, which this was not. Being aware that the risk of bleeding complications goes up as you age is important in the decision about continuing, but that should be, again, a conversation with people's individual clinicians.
Okay, thank you. The next question is about, we know that we've learned a lot about the pre-existing conditions through what we've learned from people where autopsies were done in the Korean War, the Vietnamese War, or the Vietnam War, et cetera, that showed, the prevalence of heart conditions and whatever. And the question is about, because of that, say a little bit about the preventive actions that people may want to take apart from aspirin just to maintain their heart health.
Yes, I got a sense that, there maybe part of the question was, well, should we just assume everyone has some atherosclerosis and therefore everyone should take aspirin for an indication? And important that there are, as we talked about before, other potential interventions. Certainly healthy diet and lifestyle is part of the story, and good control of blood pressure, all things that have gotten, although we wish it was even better, since the era of certainly the Korean War. And we've seen that reflected in dropping rates of heart attacks, and in particular in this country. The introduction of statins, as I mentioned, plays no small part too. So aspirin is just one tool in the armamentarium to prevent heart attacks or strokes. Healthy lifestyle, good control of blood pressure, diabetes treatment, and management of risks with statins are all potential alternatives. The goal again is to continue the trend toward lowering cardiovascular mortality in the United States.
Okay, thank
and
you.
Everywhere.
And everywhere. I think you've addressed, there was another part of this question about the impact of aspirin on colorectal cancer risk. And I think you've touched on that. And then there's another question about what can we do to lower body inflammation, which I have to say, I think we could spend the next week here talking about that. But Michael, I don't know if you want to say a few words about that.
Sure. So, there are many types of inflammation, and inflammation can be a good thing when we're trying to heal something. So we don't necessarily want to block all inflammation. I mentioned that a hot topic of research is the effect on statins that seems to be above and beyond the cholesterol lowering effect. Guidelines have actually moved suggesting that rather than what we used to do, shooting for a target, say LDL level, that the key is getting people on a good dose of the right statin that they can tolerate. And that may be more important than the cholesterol targeting, given these other effects. So I think we're still learning about when inflammation is good, when it's bad, what we may want to do in terms of making a difference. And that may be part of the story with statins. Was there a part A of that question?
No, I think that was okay. It. So I am just checking to see. I don't think you all are usually not a bad. So I just want to make sure that there aren't other questions or other clarifications. I think we've heard about a lot of different things. Michael, are you?
Yeah, someone sent a question kind of to me rather than to everyone.
Oh, okay.
It doesn't look private. It says, what about low dose aspirin for someone in their 80s who's had a heart attack and a bypass a long time ago? Again, that's not what our recommendation is about. That kind of history would swing the equation toward wanting to continue aspirin, certainly not stopping it, but acknowledging that people in their 80s are just going to be at higher risk for the bleeding complications of aspirin. I used to say in my practice to people, everything we do has some risk, even giving an aspirin, and now here we are talking about it.
Yeah. So another question that has come in, are there any gender related differences in recommendations for aspirin between men, women, et cetera?
Yeah, we always look for data in subgroups and to see whether particular populations, whether based on sex or race and ethnicity should tailor our recommendations, we're often frustrated by lack of evidence. There's actually evidence from an old Doctors' Health study in men and the Women's Health Initiative in women about aspirin treatment. And we could not find evidence enough to make a different gender-specific recommendation. So again, now, when you go to the pooled cohort equation to estimate risk, women are going to be at lower risk than men. So that in itself may mean that they're more likely to have that greater than 10%. They're less likely to have the higher than 10% risk that we would urge trigger a conversation about aspirin. So it acknowledges they're at lower risk, but if they're at the same risk as a man, then it looks like aspirin would have similar benefits and harms.
Okay. I don't see any more questions in the chat. And so I just want to see if Dr. Russell has any closing comments, and then I think we'll try to get you out there to get some more vitamin D.
That was all I was going to say. We don't make vitamin D between November and April. So get outside and get some sunshine.
Great.
Thank you, everyone,
Have a
for
happy
joining
Thanksgiving.
today. Have
Thanks
a
for your
wonderful
attention.
Thanksgiving. And thank you, Dr. Berry and Dr. Russell.
My
This was
pleasure.
really-
Bye-bye all.
Bye-bye.